This is a question time. If anybody have a question, please do. Thank you. Dr. Khaja.
Thank you. Thank you, sir, everybody, for excellent presentations. My question is to Dr. Mustafa, please. Just with regards to bridging, you mentioned that enoxaparin is inefficient in bridging. Can you hear me?
Can you make it louder, please?
Okay, it's just a question with regards to bridging. When you spoke about bridging and dual antiplatelet therapy, if we have a patient who's having surgery, say urgent surgery or emergency surgery, and he fits the criteria to stop the dual antiplatelet surgery. Usually you stop only the aspirin, we continue the aspirin, you stop the clopidogrel, and you said that bridging is not efficient. So the normal practice, or what we do in Kuwait normally, most people do, is that they give a therapeutic dose of enoxaparin. Should we do that, or should we not do it altogether because it's not effective?
It has been shown, thank you for the question, it has been shown clearly that there is no benefit for low molecular weight heparin or unfractionated heparin. It doesn't work, it doesn't have the same mechanism of action of clopidogrel or aspirin. So basically, we have tried it, other people have tried it, studies has tried it, guideline has came out with it, it's not effective, it doesn't work. So you want to give it for other purposes, that's different. But you want to give it for prevention of stent thrombosis, has nothing. It's not going to make any difference.
Thank
you. Any question, Doctora? Doctora, yes. Dr. Huda, please.
A question to Dr. Mustafa Rida again. Regarding what you've mentioned about over-investigating the intermediate and high-risk patient, mind you, the low-risk patients, that we shouldn't be doing this provided that they have good functional capacity. I used to have the same belief till I came here, till one of my colleagues, who's probably not here now, you probably know who he is, was opposing me, saying that if you're not going to investigate people and rely on their history, then you're going to end up with surprises because people don't give you good history. And to tell you the truth, I had not many, but one or two surprises where people were telling us that they have good functional capacity, they can walk for long distances, and they can do this and that, and then they end up with a problem, and then you go and do an echo on them, and they end up with a very low ejection fraction. So how do you find your experience, since you're obviously seeing a lot of these patients with this regard?
Now, we know that patients don't benefit much. Nowadays, the practice is shifting. If you look at the percentage of coronary interventions being done today, we know that over 80% of the coronary interventions nowadays in well-respected centers are done for ACSs, basically an STMI, unstable angina, and ST elevation MI, and only 20-25% of patients are for those who have stable coronary artery disease with progressive uncontrolled symptoms. So we know that patients with stable coronary arteries, they do better and they do good with good medical therapy. And there are many trials showing that. One of them is Courage trial and some other trials. So we know that coronary intervention does not improve the outcome for stable coronary artery. This is number one. And number two, if you have a patient who's been asymptomatic and stable on medical therapy, and I assume that the patient has definitely coronary artery disease. I'm not talking about somebody who does not have a coronary artery disease, has stable coronary artery disease and has reasonable functional status. We are talking about a functional capacity of more than 4 METs. We are not talking about somebody who's going to be running the marathon. We're talking about somebody who's able to walk from here to the parking lot. So if he's able to do that, and there are some criteria or some sort of methods of estimating their functional capacity. You are not asking the patient to do exercise in order to create a knowledge of their functional capacity, the day-to-day activities. So one of them is the Duke's criteria for assessment of a functional capacity. If you're able to go to the toilet, that's 2.5 meters, by the way. If you're able to go from your bed to the toilet, it's 2.5 meters. So basically, you are asking a very simple question. The problem with the surgery, the non-cardiac surgery or any cardiac surgery, is the hemodynamic shifts that Dr. Yang explained, as well as the volume status change during the procedure and the bleeding. So if you are able to control those factors, you're going to be able to control your patient. So doing unnecessary testing is going to basically create more trouble. This is my feeling, and I believe, you know, for a patient to go for a laparoscopic cholecystectomy and to have a stress myoview, given that he's asymptomatic or, you know, reasonably asymptomatic and reasonably functional, doing a stress myoview and finding a small area of ischemia in the inferior or lateral wall, and then going for a coronary angiography and ending putting a stent and then delaying his procedure for another year. And nowadays, as you know, we are all utilizing 99% of our stents are drug-eluting stents, third generation, second generations, and so forth. So basically, delaying your procedure for 1 year, subjecting to the patient for acute cholecystitis, gallbladder abscess, pancreatic problems, and so forth. So I believe if you're able, in a reasonable way, to assess the functional capacity of the patient, I think that would be more than enough to assess the function. I'm not talking about LV function, you know, this is something else. I'm talking about evaluation of the coronary artery disease, and this is the most important thing, by the way. Again, looking at the patient, if you want to assess the presence or absence of heart failure, again, this is a clinical judgment. It's not an echocardiographic judgment. Echocardiography tells you the functional status of the heart, yes, but it doesn't tell you the clinical. It's not equal to the clinical parameter, although nowadays there are some parameters in echocardiography which can tell you the volume status. But clinical judgment is more important than any other ancillary testing. I mean, of course, if you hear a loud murmur, if you hear, you know, crips, if you hear, you know, so many stuff, you will have to go further and investigate this patient for the sake of that particular diagnosis, not for the sake of going for a laparoscopic cholecystectomy. And of course, you're not going to take a patient with an acute ST elevation MI for surgery, non-cardiac surgery, and you're not going to take a patient with active heart failure, class 3 or class 4 for an elective procedure, definitely. We're talking about, reasonable, unreasonable, unnecessary testing for patients who are going for simple procedures. I think that's for me is too much of a kill to do these types of tests. I don't think you should do tests just because the patient is going for a non-cardiac procedure, just for that particular sake. It's a waste of, most of the time, I'm not saying all the time, most of the time it's a waste of resource.
Prof. Yang, want to add something yet?
I think another way of approaching this is if you look at 100 people that you do the investigations on, how many of those people actually go on to have uneventful events or non-cardiac surgery? And this is why I showed the Mason study from 1995. This is not new. We always knew this. What we found when you look at 100 people coming for non-cardiac surgery and we decide to do all sorts of investigations, the result is the investigations are not harmless. And we end up with the risk-benefit ratio of doing more harm than actually benefit. And the trouble is we do have maybe 0.5%, maybe 1%, depending on where you practice, maybe even a higher percentage of patients who will get into trouble that you don't think that they're going to get into trouble. If my comment earlier about echocardiography means to you that you should do pre-op echo, no, that's not what I meant. Because there are good trials to show that pre-op echo does not change anything. What I meant is when something goes wrong, you really should have the capabilities to now put in the TEE probe to quickly tell you what's going on. That's the 0.5, maybe 1 or 2% of the cases that you don't expect something to happen and something happens. That does happen, and I'm not being unrealistic in saying that. However, when you have someone who is stable and coming for elective surgery, the more tests you do, the more harm we know we cause.
Thank you. You want to add something? Yeah.
Just one more thing. I think the problem sometimes is the medical or the fear from medical legal, litigations, and problems. And one of our colleagues mentioned that before the meeting, that we all know that there is no benefit from these tests, and sometimes it reflects more harm than benefit. But we are worried about getting sued, and one of the members of the committee of an investigation team can say, why didn't you stress my view? Well, you have all of the data available. The data is available, the trials are available, the guidelines which has been put is available, and basically it's very well argumentative. There are more sincere people in the medical community than those who are not sincere. This is my belief. Thanks.
Yeah, I just want to clarify, because you did mention echo in a positive manner, and I think you're really talking about the benefit of echo in an acute episode, not as a pre-op assessment tool. Is it?
Sorry, you're talking about the echo? Yeah. With any of the cardiac output monitoring, and in the context of we have diseases that we can never predict how they're going to behave. For example, I use the example of the physiology of the acute coronary syndrome type 1. I can never predict when the plaque's going to rupture, and I've also had a colleague one time giving an anesthetic to a patient who just happened to decide to have a pulmonary embolism, a saddle pulmonary embolism, right in the middle of the case. Well, who's going to predict that? You can't predict that. You can do all the pre-op tests you want, you can't predict that. That's when you need the capability to quickly diagnose what's going on. And right now, the tool that has reliably given us that is the interruptive echo, the TEE.
Any more questions? Yes, Dr. Khashti.
Dr. Hussain, thank you very much for you and for your team. Very interesting lectures. My question to Dr. Ruhiddin, you mentioned that one patient dies every 2 minutes. I couldn't get it. What did you mean by this?
It's globally, not this. It's
okay, which is very. It is a really big number.
Yes.
I don't know how is it in Kuwait. If you have any comment. And my second question: did you evaluate the protocol which you are using now, which you talked about how you do it and all that? And if you see it successful, are you planning to implement it in other hospitals? And actually, I enjoyed the discussion at the end. Thank you very much.
Thank you for your question. As regard to the hemorrhage of the massive bleeding, it's a problem all over the world. Probably I presented from a registry of 2003, but even if you follow up to 2016, still major hemorrhage in as in the form of PPH is still as a direct cause of maternal death. So I will not be surprised if 2 minutes one mother die from one reason, direct or indirect. As regarding whether to implement what I said at the beginning, this is still a premature kind of experience. And I have been asked by several bodies that why don't I apply such my knowledge or this kind of protocol into all the hospital. But frankly to tell you, Dr. I'm responsible of all the risk I'm subjecting the patient and all the benefit. So this has to come through a consensus kind of a group. We meet together. I cannot push one kind of a treatment into and push it to everybody. If anybody wants, we have to sit. We have to the way we are doing it. It should be through kind of a collaboration. Since we have a kind of a teamwork, it's a collaboration between the obstetrician, the anesthesia people, ICU people, as well as the hematologist. We can sit and reach to a consensus. Whether I found probably I can review or see whether it is successful or not, and the timing, how much I'm controlling the bleeding. Before the bleeding can take more 45 minutes, 1 hour. During 1 week, it came by surprise when I started to implement this kind of strategy or kind of a treatment. By luck, we had 3 cases. The first one was a patient that all of a sudden, when they called me, she was in a shock. So it was a little bit late. So when we started to introduce the treatment, we could manage her يعني بس it took time. The second case, because we were well prepared, in less than half an hour or probably 45 minutes finished. The surprising was during the weekend we had one of the worst cases of perioperative according to the obstetrician, and we could finish it in 30 minutes. You know, there was a bleeding, but was well controlled, and this is not because of my effort. I have a very skillful doctor at that time during the week, and we have very skillful and professional people in the ICU and the obstetrician. We are a team. Yani the good thing about maternity, if for example, we have a high-risk case, they accept if I say I want a consultant to do that. They يعني إحنا نمون على بعض بهالدرجة دكتور عرفت شلون؟ إنه we for the sake of the patient we can suggest who do the operation in one of the time. So and I think my experience is still I need to build more and more. لأن everybody has the right to question me why on earth you are introducing a drug that there is no consensus still on and using it. But I really happy with the drug. لأن for the last 2 years, alhamdulillah, ما في morbidity related to the bleeding. The timing of controlling the bleeding is an indicator that you are not in a big fuss, you know, because of the bleeding. بعدين the amount of the consumption of the factors like the cryo, the FFP, definitely relatively أقل, because it was a short talk. Within less than 48, I couldn't prepare my statistic.
Last response of Prof. Yang, you want to respond back?
I apologize, I will keep it very short. One of the things about this sort of events, for most centers, it occurs maybe 2-3 times a year, maybe 4 or 5 times a year, and in some centers maybe once every 2 years. And then the problem becomes the team isn't used to practicing this together. To give you an example, we had a drill, and we call it a massive blood loss protocol. There's an alert that goes out hospital-wide. And to our surprise, all the porters who need to transport the blood ran to the emergency department and waited for orders. And we wanted them in the birthing unit. These little things that if we did not practice, when it actually is occurring, the people are not used to it and you don't have time to correct it. And this is one of the examples where we'll say, I don't know if Dr. Bolke is here, where the simulation, where the drills actually need to occur. I'd like to ask a question. You mentioned a lot of the blood taking and being waiting. Are you using point-of-care testing?
Point of care testing. Yes, it's available in most hospitals in Kuwait now. A lot of ICUs and theaters do have them. Yeah, making a difference. Thank you very much. Thank you.